Hey everyone, welcome to another episode of the I Believe podcast. And this one is extra special because we are bringing you some very cutting edge updated information from some amazing doctors. So I'm going to have them introduce themselves and then we're going to get into what we're talking about.
Hi, my name is Dr. Juan Alban. I'm a Chief Hematology Oncology Fellow at Northwestern University.
Hi, I'm Sunandana Chandra. I'm a melanoma medical oncologist at Northwestern.
I'm Scott Walter. I'm a ocular oncologist in Hartford, Connecticut.
Hello, I'm Jose Lutzky. I'm a medical oncologist specializing in melanoma at the University of Miami Sylvester Cancer Center.
Hi, I'm Meredith McKean. I'm a medical oncologist based here in Nashville with Sarah Cannon Research Institute.
Yeah, hi, I'm Sanjay Chandrasekaran. I'm a medical oncologist at UT Southwestern in Dallas, Texas.
Welcome everybody and thank you so much for being here. This means a lot to patients, caregivers, everyone that's experienced ocular melanoma, that you guys are putting so much effort and dedication into not only taking care of patients, but trying to help find a cure. So we're very appreciative of your time and everything you're doing, but also that you're taking time out of your day to be here with us and explain this to patients. This is huge that you're doing this and we're very, very grateful. So would you guys like to give a little background on what COOG is, because some people listening right now might be like, oh, I've never heard of COOG.
Yeah, so the COOG stands for the Collaborative Ocular Oncology Group. This started off as kind of a small group of ocular oncologists who were, scientifically curious and aligned with the work of Dr. Bill Harbour, J. William Harbour, who is known for developing the gene expression profiling test, which has now kind of become widely used as a standard of care in the United States for prognostication in uveal melanoma. And so, Bill's work kind of developed this test and then led to prospective validation of the test through a collaboration between multiple centers. And over the subsequent years, that's kind of evolved into additional testing modalities. So you've probably heard about PRAME expression and more recently the next generation sequencing for uveal melanoma associated mutations. And so the group has grown both in terms of the number of affiliated ocular oncologists and the number of tests that we've validated prospectively through this venture. And then over the past, 4 or 5 years, we started expanding our meeting to invite medical oncologists. Many of the premier ocular oncologists in our group are affiliated with really top-notch medical oncologists, and we wanted to bring them into the fold to learn from them more about what happens after we treat the eye melanoma and how we can make a difference in terms of metastatic disease, because ultimately that's really what we care most about. And so over the past several years we've had these very productive discussions at the meeting, and I think Bill Harbour and some of the other leaders in the group kind of came up with the idea of putting together a panel to come up with some consensus guidelines around metastatic surveillance. So Juan kind of took the lead on this project, and I'll kind of hand it over to him to explain the methodology and who all was included in this consensus group.
Excellent. So this project was fairly large. It spanned about 1 year. We invited 49 experts from around the country. So experts who are medical oncologists, ocular oncologists, surgical oncologists, and radiologists to participate in this project. The Delphi method, it's a method that was developed in the 1950s initially, and it's a technique to achieve consensus among a group of experts. It involves multiple rounds of questionnaires where experts anonymously provide their opinions and feedback. After each round, experts are provided a summary of responses and then are invited into a debriefing session so that we can have all the experts discuss the results of each questionnaire and revise their views. We ultimately did this 3 separate times across the year, which ultimately gave us the consensus document that has recently been published.
So, Juan, you make a great point. And also, let's not forget that this was actually a multinational effort because our colleagues in Canada were also able to join. What led to this endeavor was the recognition at one of our COOG meetings, or actually multiple meetings, that we were all surveilling our patients in various ways, using different types of imaging methods or modalities, different types of frequencies. And we realized very quickly that it behooves our patients and the field in general to try to develop some sort of consensus to help guide us and our colleagues, and also to give our patients a sense of how best to manage their surveillance. Now, of course, the problem is that there's not a lot of evidence behind these guidelines. It's a mix of data that Scott had alluded to, the gene expression profile data, the PRAME data that can help us prognosticate someone's survival who has uveal melanoma. And it was also a combination of everyone's expert opinion from all these different multidisciplinary groups to come up with some sort of consensus that we can all then follow to the best of our ability.
I might also add that for a long time, there was a lot of questioning of why do we need to do this? Why do we even have to do imaging? Or why do we have to follow patients because we don't have any treatment for them? But that has changed. Currently, we are living in one of the most productive period scientifically in understanding melanoma, uveal melanoma in particular. There's a lot of research. There are a lot of new potential treatments and some that have already been proven to be beneficial. So in this current environment, it's very important to know who is at high risk of recurring and who is not. So I think that also has prompted us to feel the urgency of trying to find the framework where we could all speak the same language.
I think that's fantastic. So you all have gotten together and published a paper with the guidelines, and it is called the Metastatic Uveal Melanoma Surveillance, a Delphi Panel Consensus. Can you explain to us what a Delphi method is and why you used it?
Most definitely. So the Delphi method, it's a wonderful method to utilize when there isn't a clear right answer, and you're trying to answer the question with many different viewpoints. So in this situation, as Jose just mentioned, everyone's doing things a little bit differently, and everyone's got their own reasonings. And so we wanted to sit down and create an iterative process or format in which we could tease out these differences in practice patterns and try to actually standardize those practice patterns across the board in the US and Canada. So this Delphi method, this technique to achieve consensus, it's really just an iterative, multiple rounds of questionnaires. So we create a questionnaire with numerous different recommendations, and we pass them on to our panelists, and we have them rate from 1 to 9 what degree they agreed with the statement in front of them. Based on those scores, we then went back and discussed each round of the questionnaires with our panelists so that everyone could understand what specific recommendations were popular, what recommendations were unpopular, and how we could tweak them to improve them so that we could get the largest amount of members on board with the set recommendations that were ultimately published. So this method, it really allowed us to go back to the drawing board numerous times with the feedback from a very diverse group of experts and ultimately craft very descriptive statement recommendations for each class of patients, the intermediate risk and the high risk patients. So we dive into not just the frequency of surveillance, but also the techniques. So what imaging modalities should be utilized, if and when blood testing should be utilized, and if and when PET-CTs should be utilized.
I'll just jump in there. I'm, kind of a private practice ocular oncologist out in the community setting. And so, my patients don't necessarily all have the benefit of going to a world expert a medical oncologist who specializes in uveal melanoma, right? They're more likely to see a general medical oncologist, or maybe if they're lucky, a medical oncologist that specializes in cutaneous melanoma. But they're less familiar with uveal melanoma surveillance. And so there's a lot of heterogeneity out there. Even, we're talking amongst the experts in the group, there was disagreement. But when you get out to the community ocular oncologists, medical oncologists, there's even more variability in how surveillance is being done. And so one of the things that, I think this has helped with is, providing sort of clear guidelines that we can send to community oncologists to help allow them to do this surveillance in a way that is in alignment with the world experts, that joined the panel.
And do you feel like because uveal melanoma is so rare, that makes it more challenging?
Absolutely, because most medical oncologists have probably never seen a case of uveal melanoma in their careers. They kind of get siloed into the more common cancers. And, unless they're in a major center where these patients are concentrated, they're unlikely to have managed this disease in terms of surveillance or, the management of active metastatic disease once it occurs.
Another potential advantage of this, and a very practical one, is that, and I would ask my colleagues to give their input here, is in terms of getting insurance approval. For some of the tests, and it's very inconsistent there. Some insurance companies will approve what we think is the best imaging modality for the patient, while others will not. So we're hoping if we can create this framework there that's published there, and it has the agreement of 40 plus physicians that specialize in the field, it would make it easier for us to argue with these insurance companies. But I don't know what Meredith or Sanjay have to say about that.
Yeah, I think not only is it important for other colleagues, medical oncologists, patients, but also insurance companies to educate all of them on the differences between cutaneous and uveal melanoma, right? And how we determine high-risk cutaneous melanoma is very different than uveal melanoma. How we follow it's very different. And so I think the more we can highlight those differences, the more we can really advocate for our patients and be able to say, look, we know the risk of recurrence in the liver is the most concerning location. And so this is why we need to follow patients with intensive monitoring in the liver, for example, with MRI of the liver, triple phase CT, and especially for the patients that with the risk prognostic scores that we have now, we know which patients are at higher risk and which ones we need to be more intensive in our screenings versus patients that are low risk that we can say, you don't need that same level of intensity in your follow-up.
Traditionally, or historically, I should say, uveal melanoma was more of a clinical diagnosis. But yet, over the past few years, we have some very clear and clean data showing us that perhaps if we had some more biopsies being done and we had some tissue to actually analyze, we could really prognosticate people who are at low, medium, and high risk, or what we call low, intermediate, or high risk. So also one of my hopes with this consensus document is that it will encourage many of our colleagues who are around the country to actually consider doing a biopsy, because that actually would change surveillance, and it can have quite a significant impact on whether someone's low risk or high risk.
One of the nice things about the way the Delphi is presented, and bearing in mind we have national guidelines for uveal melanoma, as there are committees that sit down and review this, but I think for practicing oncologists that are working through national guidelines, it's nice to have, in a way, something that you can read that's a conversation amongst physicians who are making these decisions and recommending how to make those decisions. And that's why, as the way the Delphi publication is presented, it kind of works through these scenarios to finally say, hey, this is how the group achieved these recommendations. So it's less of an ingredients list and more of a recipe to allow someone to work through the scenario. And I think that's why it's very complementary to what exists, and certainly I think offers context to both providers and patients and payers and family members as to why we're doing what we're doing and the decisions are being made.
I think that's amazing and so needed. Dr. McKean, can you walk us through the pattern of metastatic spread?
Yeah, so unlike other cancers where we can check a lymph node, say at the time of diagnosis, in uveal melanoma, we're limited to features of the primary tumor to understand risk factors and the biopsy. Because with uveal melanoma, it's more likely to spread through the blood. And so because of this, the biggest concern is that this cancer can return in the liver. And oftentimes patients don't have any symptoms. Their labs may be normal if blood work is checked. And so this is why we need intensive monitoring of the liver. Other locations that uveal melanoma can recur is places like the lungs, bone, other places in the abdomen. And so we need comprehensive imaging, but it really does center on good imaging of the liver in addition to these other locations. Uveal melanoma as a rare disease, we haven't had randomized trials to be able to look at different screening mechanisms. And so a lot of this is based on our clinical care of patients and what we've seen as the best test to be able to detect metastatic disease.
One of the great tools that we have now is this gene expression profiling in PRAME, which we're using clinically to help estimate the likelihood of metastatic disease progression. So at the time of tumor diagnosis, an ocular oncologist often will perform a biopsy of the tumor and send some genetic material for gene expression profiling. And that comes back with the result of either class 1 or class 2. In addition, we now also do PRAME expression profiling on the same specimen. So that further subdivides patients into class 1 PRAME negative, which is the lowest risk subgroup. Those patients have a less than 5% risk of developing metastatic disease progression over 5 years. The second group is class 1 PRAME positive. So these patients still have a relatively low risk of metastatic disease progression, but it's about 20% of patients who will develop metastatic disease over the course of 5 years. And the average time to develop metastasis in this population is about 3 years from diagnosis. Then we get into the class 2 tumors. Unfortunately, class 2 tumors have a much higher likelihood of metastasizing. It's around 50% of these patients who will go on to develop metastatic disease. And if we subdivide the class 2 population into the PRAME negative versus PRAME positive subpopulations, there's a slightly lower risk of disease progression in class 2 PRAME negative versus the higher rate of disease progression in class 2 PRAME positive. So basically, the patients who are class 2 PRAME positive are our highest risk group. They have a roughly 60% chance of developing metastatic disease within 5 years. And about half of the patients who will develop metastatic disease will do so within a year and a half of diagnosis. So the latency to metastasis is also shorter in the class 2 PRAME positive subgroup. In the class 2 PRAME negative subgroup, it's a little under 50% of patients who will develop metastatic disease, and the latency is a little longer. So the average time to developing metastatic disease is about 2 years from diagnosis. So the availability of this really detailed algorithm for determining metastatic risk has allowed us to develop more personalized surveillance guidelines for patients in different risk categories. And that's really what this consensus is all about.
I think it's interesting to notice also that for some of these subgroups that don't have a very high recurrence rate, some of these patients may recur late, sometimes 10 years later. So recognizing this, we included long-term surveillance in these guidelines. The main reason why we want to know who is going to recur and when is because we may have the opportunity to intervene to prevent those recurrences. And we're beginning to see now new clinical trials trying to prevent or delay recurrence in those very high-risk cases.
So I think at this point we can discuss a little bit our findings and the consensus recommendations. So if we break down our recommendations based on the risk classification, let's quickly revisit what that risk classification is. So for the intermediate risk, these are patients who are class 1 by gene expression profile in PRAME positive, or disomy 3 with gain of chromosome 8q, or SF3B1 mutation, or if we use the AJCC classification, this would be a T2 or T3 tumor. For these patients, we recommend that they undergo screening for metastatic disease with a frequency of every 3 to 6 months for 5 years, and thereafter annually for at least 10 years from diagnosis. We recommend that they undergo cross-sectional imaging, meaning CT abdomen or MRI abdomen, to surveil for metastatic disease specifically in the liver. We do note that we have a preference towards contrast-enhanced MRI abdomen over CT abdomen and also over hepatic ultrasound. With regards to surveillance of the thorax or the chest, we recommend that patients undergo a CT of the chest, which is combined with this hepatic imaging, but we don't dictate the specific frequency for the CT of the chest, meaning that patients can undergo CT chest at a reduced frequency in comparison to the abdominal imaging. Now, with regards to the high-risk group, the high-risk patients are those who are class 2 by gene expression profile, regardless of their PRAME, meaning PRAME positive or PRAME negative. They can also fall into this high-risk group if they have monosomy 3, regardless of chromosome 8q, have a BAP1 mutation, or are T4 by AJCC. For these patients, we recommend an increased frequency. We want them to undergo metastatic disease surveillance with a minimum frequency of every 3 to 6 months for years 1 through 5, then every 6 to 12 months for years 6 through 10, and then surveillance imaging beyond 10 years can be considered. For these patients, we similarly recommend the use of contrast-enhanced CT abdomen or MRI over the use of a hepatic ultrasound. For these patients, we also recommend the use of a CT chest, which can be combined with hepatic imaging for surveillance of metastatic disease in the thorax, although this can also be performed at a reduced frequency. Lastly, we similarly note that we have a preference towards MRI of the abdomen over CT abdomen in this high-risk population. If we take a step away from our risk classifications, we did also provide some general guidelines regardless of the risk classes. With regards to PET-CTs, we did not feel that they were reliable enough in picking up the small amount of metastasis to the liver. And so as a result, we recommend the use of MRI or CT abdomen in its place. With regards to hepatic ultrasound or ultrasound of the liver, unfortunately, this tends to be a very technically difficult exam and is very much dependent on the expertise of the ultrasonographer. And so as a result, we feel that there's too much variability in that test's capacity to pick up metastatic disease. So similarly, we recommend the use of MRI or CT in place of hepatic ultrasound. And lastly, we did not feel that the routine blood work necessarily added much in ways of picking up metastatic disease, meaning it is more often than not that these tests do not provide us any additional information when done on a routine basis.
So I think one thing that's important to realize and for our patients to understand is not every anatomic part of the body can be imaged identically compared to another part. So, for example, for the abdomen and pelvis, we often use contrast to really help delineate, small structures and gives us a lot of detail. It's highly sensitive, highly specific. However, for example, for the lungs, for the chest, especially if we're not necessarily concerned about lymph nodal involvement, we actually don't need contrast. So those are just examples of, we just have to be very thoughtful when we're ordering these different imaging tests to make sure that we order the best test possible to give us the most information, and B, spare our patients additional tests that may not be that much more meaningful. One, you had mentioned prognostic factors that we look at other than just gene expression profile. You mentioned PRAME, you mentioned chromosomal analysis, the genetics of the tumor size. I think it bears worth repeating that having it be a variety of prognostic factors and have that being included in this document, we hope will allow more people to be able to use it, because we acknowledge that not everyone has access to gene expression profiling. Different centers may have different protocols when trying to prognosticate the tumors. So I think this document allows for multiple variables to be taken into account. And then finally, what sets uveal melanoma apart from many other cancers is that it can have a long latency in some scenarios. And so extending our scan frequency when appropriate, I think will also help keep our patients safe with respect to helping us detect recurrences.
I think an interesting finding from this was it did, I think, de-escalate surveillance imaging for some patients. So the analysis showed that while the national guidelines for patients that are class 1B by GEP but don't have PRAME expression were initially thought to be an intermediate risk category with a higher risk for developing disease, based purely off of the Collaborative Oncology Group report number 2. Using that data and using a consensus statement, we can, I think, confidently say, hey, those are patients where we may not need to scan as frequently. That if it's class 1B PRAME negative, that's actually a low risk population, that a consensus group feels that this is a space where we could move from a 6-month interval, maybe even de-escalating. While again, the consensus group at least didn't completely finalize what low risk patients should ideally be receiving in terms of scans. I think it's nice for patients to understand, hey, maybe my risk is a little bit better. Maybe I have a better chance of beating this and not developing recurrence of my melanoma.
One thing that comes up often in clinic is the time toxicity and the financial toxicity of all the testing that we do. So for a lot of our patients at Northwestern, they're traveling from really quite far away to see us in the clinic. And so if we are recommending imaging, that is an additional trip often to the downtown center. And so now being able to point to an expert consensus and feel very confident in the recommendations that we're providing to patients makes the discussions a lot easier for us in the clinic, not just to provide support, but also to counsel patients. If they're spending hours or days performing the tests that we're asking of them, then I think it's really important that we have the best data out there to really guide those decisions. And so I'm very glad that now through this effort, we can really provide those recommendations and those frequencies with very high confidence.
Can I ask you as a wrap-up question, what's next for COOG?
I think one of the questions that persists is just how long do we continue to surveil patients, because the goal of the COOG data and how to implement that, as we discussed, is to not only understand which patients to intensify screening, but also which patients to de-intensify. And so right now, the consensus was that it really should be up to the individual, the provider. High-risk patients, we've started to give guidelines up to 10 years. But I see that as one of the issues that I hope that we are able to address even better in the future once we have longer follow-up of these patients that have been participating in the COOG data.
That makes a lot of sense. Is there anything else you guys want to touch before we wrap up?
So I think this effort really highlights how when a group of experts come together and identify an unmet need, in this case, some further guidance for how to surveil our patients based on the data that we do have available, that you can achieve the the objective. And so, I hope that this document, this consensus guideline, is actually helpful not only to our colleagues around the country, but also, most importantly, for our patients.
Another benefit of this is that if it gets adopted by other medical oncologists, particularly the people that are not that familiar with uveal melanoma, it will create a database that we can do real world assessments in a much more reliable way. Because right now, if we want to see in the real world how patients are doing to get a specific treatment, for example, if people are being assessed at different intervals, different types of imaging, it may not be very reliable. And that's why standardization of monitoring of patients is important.
And I think ultimately, we want to go back to thanking patients, right? If it was because patients have all signed up to say, yes, I want to participate in the COOG study, and please use my data to help other patients, that we now have all this information that we can look back and try to develop these guidelines. And patients were signing up for this well before, as Dr. Lutzky said, well before we had any effective treatments. But it was, those patients that donated their time, effort, and allowed us to follow them and to look at their data, that we now have this really robust data set that helps inform surveillance patterns, helps us identify hopefully high-risk patients for adjuvant trials. It's always interesting, patients in clinic, if they, we get to the 5-year mark and they say, well, what do we do? And I say, well, thanks to you, we're getting more information and a better idea. And they say, oh, what am I participating in? Because I know at time of diagnosis, it's can be very overwhelming, and it's a patient saying, sure, what else can I do to help at that moment? But it really all comes back to those patients being so thankless with their time and all their information.
Absolutely. Thank you all so much for being here and explaining this to us in a real world way that a patient can actually understand it, because it's such valuable information. And I think that patients hear about this and they get so excited, but they don't know how to access the information or how to, make it understandable or digestible. So the fact that you guys came and explained this to us and took time out of your day, it means the world to all of us. And we're so grateful. So thank you so very much. For everyone watching, thank you for tuning in. This podcast does not function without our viewers, so thank you so much. Please like, subscribe, leave us a comment, let us know what you thought. If you have any questions for the doctors, drop those as well. We'll see if we can get answers for you. And then thank you to our sponsors. This podcast also does not function without the sponsors. We're incredibly grateful, so check out their websites. They're doing some amazing things. And then check out A Cure Insight's website. There's a button at the top to subscribe to our newsletter. It goes out once a month and it has all kinds of great information to keep you up to date. Also check out our 5Ks. There's probably one coming somewhere near you, so you can check that out. You can also do it virtually if you can't find one near you, or if you just would like to do it on your own. And we also have our Cure Companions program going on right now. If you need a buddy, if you need somebody to go through this journey with, that's a great resource. And don't forget about our Zoom meetings every Tuesday night. There's a regular room and a metastatic, so you can choose the room that fits your comfort level and just be with some people who understand what you're going through. So with that, I'm going to leave you. I hope you all have a wonderful week, and we will see you next week.